Hi, my name is Dal, and I will be discussing the breastfeeding challenge that presents with inverted nipples in the preterm infant. I'll be addressing these topics using the situated clinical decision-making framework. Now, what is the framework? So the situated clinical decision-making framework is a tool healthcare professionals use to assist in making decisions based on more than a basic understanding of nursing, the patient's reported needs, and the documented care plans. So the situated decision-making framework consists of 5 components, which are knowledge, cues, judgment, decision, and evaluation of outcomes. Now, in the case of mom, that's who we'll start with first. So the first portion of the framework we'll discuss is knowledge, and this is going to be relating to inverted nipples. So, what are inverted nipples? For most women, inverted nipples are of congenital cause. A truly inverted nipple is caused by adhesions at the base of the nipple that bind the skin to the underlying tissue. While the skin does become more elastic during the 3rd trimester of pregnancy in preparation for nursing, some cells in the nipple and areola may stay attached. So, now, babies are breastfed, not nipple fed, and if baby is able to take a good mouthful of breast, most types of inverted or flat nipples will not cause a problem during breastfeeding. However, some types of nipples are harder for baby to latch onto, especially at first, but in most cases, patience, persistence, proper latch-on technique, and perhaps a few other helpful measures will pay off. So, flat or inverted. You can determine whether or not you have flat or inverted nipples by doing a simple pinch test. Gently compress your areola about an inch behind your nipple. If it does not protrude or become erect, then it is considered to be flat. If your nipple inverts, retracts into the skin, or becomes concave, it is considered to be inverted. True inverted or flat nipples also will not become erect when stimulated or cold. If your nipples protrude when stimulated as described above, they are not truly inverted and do not need special treatment in order to breastfeed. There's also different types of inverted nipples. One type of inverted nipple known as dimpled or folded is in which only part of the nipple is inverted and will not protrude when stimulated but can be pulled out manually with the fingers. Unfortunately, in most cases, the nipple will not stay pulled out and will perhaps benefit from special treatment measures. There are also varying degrees of nipple inversion, from slightly inverted, which would be grade 1, to severely inverted, which is grade 3. So that's just a look at the different grades of inversion. Now, then we're going to move on now to cues. So maternal cues that we can look at are, do nipples show signs and symptoms of nipple inversion? Is mother showing signs of pain on feeding? Are cracked bleeding nipples? Is there engorgement? Is there decreased milk supply? So with engorgement, not having effective emptying of the breast, and then decreased milk supply, baby may not have a proper latch, so it's not effectively emptying the breast, which is not producing or stimulating the production of milk, so you get decreased milk supply. Some judgment. So what is affecting the feeding relationship? A skin to skin being promoted and supported. In the case of the preterm infant, sometimes they're separated from mom, they're in the NICU, or they've got other medical measures that need to be put in place, so they're not with mom all the time, or mom doesn't have ready access to them. What are we doing to support this and maximize this exposure between mom and baby? Is the mother-baby diet developing a relationship? Does a lactation consultant, a midwife, or other healthcare professional need to be consulted? How can we support the mother and child diet to breastfeed effectively? We'll come back to this, and this is where we'll talk about the 3 important rules of breastfeeding. Feed the infant, move the milk, help the diet to learn to breastfeed. But first, we're going to move on to the infant. So, the preterm infant. So, an infant is considered preterm if it's born less than 37 weeks gestation. A late preterm infant is born between 34 to 36 weeks gestation. Preterm infants face a feeding challenge because they have not developed the coordination of the suck-swallow breathing. Given that their neurological immaturity. They also have an inability to coordinate states. so their sleep-wake cycle might be a little bit off. They may fall asleep easily at the breast, not be able to stay awake long enough to feed effectively and empty the breast effectively. And they also have difficulty giving clear cues for hunger or satiety. So mom might not know that they're hungry because they might not be waking up and acting like they're hungry, or mom might think they're full because they're acting like they've had enough milk, whereas it's just their states are a little bit uncoordinated. All these facts add to our breastfeeding challenge, as mom may not breastfeed as long or as often due to missed cues or no cues, and this will affect the milk production. So what are some cues, signs of effective feeding? Sustained rhythmic suck swallow patterns and occasional gulps, audible swallowing, relaxed hands and feet, moist mouth, satisfied after feeding, minimum of 8 to 12 feedings in 24 hours. Baby will gain some weight, and then you'll see 5 to 6 wet diapers every 24 hours at about day 5 to 6. Ineffective feeds, you'd see drops in birth weight, increased fussiness after feeding, decreased output, and this is where you could start to see some of that jaundice coming in, fussiness, just not a happy baby. So what factors could be affecting the breastfeeding relationship? Is there ample opportunity for skin to skin? Are we providing this opportunity? Do we need to bring in a lactation consultant, midwife, or public health nurse? What is our priority for breastfeeding? This leads up to the 3 rules. The first one being feed the infant. So important. Early and often. Is the infant getting enough food appropriate to the age and weight? We need to move the milk. Help the dyad learn to breastfeed. How is the relationship working for both partners? When infants can't take care of rule number 1 directly at the breast, other options include dropper or syringe, spoon, cup, feeding tube at the breast, bottle, or nipple shields. Now, the use of nipple shields for preterm infants in the NICU is reported to allow better milk transfer by reducing the effort needed to maintain a latch. So the success of this intervention depends on establishing a ready milk supply towards removing the milk shield when the infant is able to maintain latch without the shield, and carefully monitoring and support are necessary. So rule 2, move the milk. Can we help increase demand by feeding more frequently and effectively? Increase frequency and durations of feeding, including night feedings. Improve latch, and we'll really have to be supportive of mom with preterm infants and inverted nipples, as being just patient and helping her figure out the right way for her and her baby to be able to feed. Consider lots of skin to skin, promote lots of skin to skin, because it'll conserve energy and help the parent identify baby's cues. Stimulate infant to keep them awake enough to feed. Do breast compressions while breastfeeding. Offer both breasts at each feeding. Rule 3, help the dyad learn to breastfeed. Some suggestions for the mother to try: work on techniques of latch and position, try a different position or location. Lots of skin to skin again, which seems to be a reoccurring theme here. Look for optimal times to feed the baby. Be gentle with baby, kind of coax them into the breast, not frustrating them more by fighting with them, and try enticing them. So some decisions: we should try different methods of feeding. Should we involve other healthcare professionals? Have we supported both mom and child dyad? And at the end, the evaluation we can look at is mother pain-free while feeding? Is she confident with her feeding? Does mom feel supported? For baby, is baby gaining weight? Does baby have adequate output? Is baby satisfied?